Good afternoon, everybody. Welcome back. How are you? So I'm Helen Ofosu. I'm here today as the chair of the Black Psychology section within the Canadian Psychological Association. We're happy to be sponsoring this plenary session. So I'm going to start by introducing Dr. Angela Haeny. She is an assistant professor of psychiatry, and she leads the Racial Equity and Addiction Lab. The acronym is REAL, at the Yale School of Medicine. She's a licensed clinical psychologist with a specialty in substance abuse disorders. Dr. Haeny is committed to eliminating racial disparities and enhancing diversity, equity, and inclusion, which cuts across all aspects of her work. Her research investigates effective alcohol and drug treatments among individuals who are underrepresented in substance use research with a focus on Black adults. Her research also involves identifying understudied risk factors for substance use and problems especially salient to Black people. Currently, Dr. Haeny's research is considering how to target racial stress and trauma and other relevant constructs in drug and alcohol treatment to improve treatment outcomes, retention, and satisfaction among Black adults. This work is funded by a 5-year Career Development Award from the National Institute on Alcohol Abuse and Alcoholism. So today, the title of our talk is For Us, By Us, Improving Black Mental Health Through Tailored Alcohol and Drug Interventions. So let's give her a very warm welcome on this cool fall afternoon.
Thank you so much for that lovely introduction. It is so wonderful to be in this room of beautiful faces. Thank you, Dr. Sana, for inviting me here to present. I'm excited to share with you a little bit about my work of incorporating racial stress and trauma in substance use treatment to improve outcomes among Black adults. So I always like to start with a land acknowledgement, and I appreciate that the city of Ottawa has their own. I was going to read that today, but you all already provided it last week or yesterday. So there's something I'd like to add, though, to that. So I'm just going to read it. So we respectfully acknowledge and honor all Indigenous communities, past, present, and future, and are grateful for their ongoing and vibrant presence. We also acknowledge the systemic policies of genocide, relocation, and assimilation that still impact many Indigenous families today. As settlers and guests on these lands, we respect the work of Indigenous leaders and families and pledge to make ongoing efforts to recognize their knowledge, creativity, and resilience. In an effort to honor and remember the violent histories and legacies of settler colonialism, we want to acknowledge that we are in a young country that has developed rapidly, and much of the economic progress has resulted from the unpaid labor and forced servitude of people of color, particularly enslaved African people. We recognize that collectively acknowledging the historical labor that has allowed our society to progress to where we are today is key in reconciling and redressing our violent history and legacy of settler colonialism. So I always like to start with that, and then I'm going to turn into talking about substance use disorders. And so the drug overdose death rate is a racial justice issue. Oh, okay. All good? Okay. So the drug overdose death rate is a racial justice issue. And national epidemiological data in the United States indicate that Black people had the greatest increase in overdose deaths. So for those of you who like to see the data, this is national epidemiological data showing the year-to-year percent change in overdose mortality rates by race and ethnicity. The yellow bar represents Black folks, and we see that Black people have the largest percent increase in overdose deaths in 2020. And we see that that's followed by American Indian and Alaska Native folks, Latine folks, and white folks. And so this is the first time since 1999 that the rate was higher among Black people than white people. And this highlights a serious need for effective treatments. This is a matter of life or death. National epidemiological data also show that among folks with a lifetime drug use disorder, we're seeing that among Black folks who meet criteria for DSM-5 lifetime drug use disorder, who reported needing treatment but not going, the prevalence was highest among Black folks. And these are data from the National Epidemiological Survey on Alcohol and Related Conditions. Similar to what was presented yesterday by Dr. Williams, there's a similar pattern in terms of the prevalence of drug use disorders being lower relative to white folks, depending on the type of substance use disorder. But when we look at combining them, substance use disorder, we see the prevalence tends to be lower among white folks. Yet, when we look at the time from first initiation to the development of problems, there tends to be a shorter period of time. We call that telescoping effect. We also see that people experience more severe disordered use, more severe problems, and experience more substance-related consequences related to their use, highlighting a need to making Black folks a priority population for improving treatment. So I recently conducted a qualitative study of Black adults with substance use disorder to understand their experiences with substance use, craving in particular, which is when we understand mechanisms that impact the development of substance use disorders that can inform or better inform our treatment approaches. And then also to understand their experiences with treatment. There's this one poignant quote that I wanted to share with you all that one of my participants said, which was, "Why am I here if they're not understanding what I'm going through?" And I feel like this quote really represents Black folks' concerns with existing substance use treatments. Now, there are different ways that you can go with this. Some folks reported that part of the issue is that there weren't providers that looked like them. Some folks said that providers were not comfortable talking about issues that were important to them, that the content of the treatment did not represent their needs. And so my research focuses on how we can improve substance use treatment to meet the needs of Black folks so that we're enhancing treatment satisfaction, retention, and outcomes. And so one way of doing that is by focusing on constructs especially relevant to Black folks. And the first example that I'll provide is on racial centrality. So racial centrality can be described as the extent to which a person's race is central to their, or important to their identity. And so using data from the FACT study, which is the Family and Community Health Study, which is a multi-site longitudinal study of health and well-being among Black families, we looked at the impact of racial discrimination on smoking outcomes, for example, and trying to understand the mechanisms that impact. So we know that racial discrimination is associated with poor substance use outcomes, including smoking. But we're seeking to understand whether or not racial centrality might mediate that association. And by identifying that can help us more precisely inform how we might tailor our treatments. And so we did find that racial centrality mediated the association between experiences of discrimination in adolescence and lower smoking in adulthood. We also found that among those who smoke, that those higher in racial centrality, who felt like their race was important for their identity, that predicted smoking cessation in adulthood. And so this is really important in terms of, this adds to the literature supporting the need to consider racial identity development, including racial centrality, which is one component of racial identity development, in our treatments in order to reduce substance use. In the substance use field, there is extensive research documenting that stress is a key factor that leads to substance use and relapse. And we know that Black folks experience racism and racial stress and trauma. And so that has been a key focus of my research. But there is a paradigm that is commonly used in the substance use field that involves using personalized imagery scripts. This was developed by Dr. Sinha and her colleagues, who's also at Yale. And it was developed to test the impact of stress and substance use outcomes to inform intervention development. So I'm just going to tell you a little bit about this lab paradigm. So these involves developing standardized personal imagery scripts It's a validated, structured approach to investigate the impact of stress on substance use outcomes. And these procedures have been well validated, and those who undergo this paradigm experience the situation as if it was happening again in the moment. So it's a very rich procedure to use to kind of understand the impact of treatments on factors like craving and other outcomes. And so this paradigm includes 3 personalized scripts. So one is focused on substance use. And so this, people report a recent situation that involved using substances, that did not involve stress, and then a stressful situation. So their most stressful situation they experienced in the past year that did not involve any substance use. And then finally, a relaxing or neutral event that didn't involve other people or substance use. And to give you a sense of the paradigm, folks who are the experimental paradigm, so folks are brought into the lab, they have a baseline period where they're encouraged to relax, and they provide ratings on craving and emotion ratings, and then they listen to an image. So the image is, let me back up. So there's 2 sessions. The first session is typically the script development session where people report on these 3 different situations. The second session, and then the second session is progressive muscle relaxation and imagery training, followed by the experimental paradigm. And then people who are experiencing when they're in the experiment, they first provide their ratings, then they listen to a recording of one of the 3 scripts, which the order is typically randomized. Then they provide their ratings again, there's a recovery period, and then they might go on to the next script, or that might happen another session. And so I'm in the process of using this paradigm to kind of understand how we might more effectively develop treatments for Black folks. But before I get into that, Dr. Sinha did conduct a thematic analysis of the stress scripts to identify what are the key themes that are identified in these scripts that people are reporting. And in this sample, it's a predominantly white sample. And so just really quickly, the majority of folks reported stressors that were relational in nature. So themes under relational included violation, and sub-themes included humiliation, abuse, crime victim, or escalation to violence. Another theme is loss, which included rejection, death, or relationship loss. Another theme is parenting, which included loss of a child, conflicts with parents, co-parent tension, and parenting engagement. Another theme is betrayal, which included false accusations, feeling used, lack of trust in or from others, feeling disrespected by others, or significant other betrayal. And then finally, isolation versus support, which included longing for support or feeling controlled and infantilized, feeling alone in the world, or reaching for support and not getting it. Other common overarching themes included environmental, which include the themes of housing and the sub-themes of loss of housing or homelessness. Another theme of legal, which included arrest, probation, incarceration, and court. And then achievement was another overarching theme, not reported as often, but certainly reported, and that included employment, so a sense of failure by self or others, loss of employment, unemployment, poor work performance and poor school performance, and then role in household, so parenting, problems or homemaker, and then finally, stressors related to medical issues, so accident, injury, illness of others, miscarriage or stillbirth. And so they didn't find any sex differences in this thematic analysis, and you can see that they don't report any racial stressors either. And so I hypothesized that if we were to look at a Black subsample of these scripts, would we see that racial stressors were reported? And so that's what I did. I conducted a thematic analysis of her data, focusing specifically among Black folks. And again, these are just general stressors that people reported. They were not asked to talk about racial stressors, but we just did a thematic analysis to see what came up when we focused on Black folks. And largely, we did replicate the themes that were in the initial thematic analysis, but you can see anything that has an asterisk by it is a new theme. Anything in red are themes reported specifically among female participants, and anything in blue are reported specifically among male participants in this subsample. And you can see that racial microaggressions popped up. Also, we see that police brutality came up as well. And then no participants reported any themes related to medical issues in the subsample, but there was a new overarching theme that we identified and labeled as institutional, and included the themes of time wasted and belittled by authority. So for the sake of time, I'm just going to give one example quote of the themes. And this is an example of a racial microaggression. So you see a substitute teacher that the school doesn't use too often. She's looking at you strangely as if she's trying to figure out who you are. Now she's staring at you. You try to ignore it, but you can feel her eyes all over you. You wonder what she wants. All of a sudden she says with a little laugh, "Oh no, you're not that one. Your hair's different. I can't tell one from the other." You can't believe that just came out of this woman's mouth. She might as well have said, "All Black people look alike." And so this highlights the importance of being intentional about the research that we're doing. We see that when Dr. Sinha conducted the thematic analysis of a majority white sample, that racial stress themes did not pop out. But when we're intentional about looking within a Black subsample, we do see that even when the scripts were not asked to elicit racial stressors, just general stressors, we're seeing racial stressors are popping up, which is what we would expect. Okay, so we did find that racial stress themes emerge. We also, I didn't talk about this, but we did see that there were sex differences, which highlights the importance of intersectionality. And this, also the fact that medical themes were not identified, it could just be that, not that folks weren't experiencing medical-related stressors, but maybe they didn't reach the level of being the most stressful event they experienced in the past year. So we want to build on this work by adapting the procedures to elicit racial stressors specifically. And so we worked with community partners. These were folks in the New Haven community, some with lived experience with substance use disorder, some were leaders in churches or other organizations within the Black community. We met with folks over Zoom for roughly an hour, and our community partners were paid $50 for their time. And we work with them to adapt the procedures. And so just to give you a sense of what the adapted prompt was after meeting with our community partners, we'd like you to describe so folks who were gonna participate in this lab paradigm and we are elicit racial stressors, this is the prompt that we use. We would like you to describe a recent situation you found most stressful that involved your race. These would be situations that made you sad, mad, or upset, in which at the moment you felt as if you could not change it. Including your description, the bodily sensations you experienced when the situation happened. Sometimes it's difficult to think of a race-related stressful situation on the spot. Focus on race-related situations that made you sad, mad, or upset. Does anything come to mind? Describe the race-related stress situation as though you were helping me to see it as if I was there with you. And then for one thing that came up when meeting with our community partners is that people might be confused or unclear about what we mean by race-related stress. So they helped us develop a prompt for how we might respond to that for those who asked. So if people were wondering, what did you mean by race-related stress? The prompt that our community partners helped us come up with is race-related stress can be described as experiences of racism that threaten the individual and can be mentally and physically and emotionally draining. Racial stress may be experienced directly through personal experiences of racism or vicariously through witnessing or hearing about another person's experience of racism. Racial stress can occur structurally through limited access to goods like healthy food and services, like quality healthcare. And some people experience racial stress in situations in which they fear their behavior is consistent with negative stereotypes of Black people. So we adapted the procedures, then we wanted to conduct a pilot study to see, do these procedures indeed function in the way that we would expect? Do they elicit a stress response in a similar way that the general stress procedures do? So we recruited 20 Black adults with past year alcohol use disorder, roughly 45% were female, and their mean age was 37. We had 2 sessions that folks participated in. The first appointment, as I mentioned earlier, was developing the scripts. Then we had a trained research assistant create the scripts and record them into about a 4.5-minute recording to be used for the experimental session. In this pilot study, we only included a racial stress condition and a neutral relaxing condition, and the order was randomized. And so we hypothesized that the racial stress image would lead to increased craving and emotional response, similar to, or relative to the neutral relaxing image, similar to what happens with the general stress image. And so that's what we found. We found that there was a greater increase in alcohol craving among those who, after hearing the racial stress image relative to the neutral image. And we also saw that there was an increase in anger, fear, sadness, anxious arousal, and a decrease in joy and relaxation reported among participants. And you can see the effect sizes for the emotion scores are relatively large. So to summarize, we were successful in adapting the stress scripts. This is a controlled, internally valid evaluation of stressors. We were successful in adapting these scripts and assessing racial stressors. We found that the racial stressors did indeed lead to increased craving and emotional response. So this provides additional evidence of the importance of including racial stressors in treatment. We do have a larger grant under review to replicate this in a larger sample. But the key thing about this paradigm is that this can be used to test the efficacy of new interventions on reducing craving among Black folks. And I didn't get into why craving is important, but this is a major target in many both pharmacological and behavioral interventions, substance use interventions, given how strong of a predictor it is of subsequent use and relapse. And that stress is a major factor that contributes to increased craving. So transitioning a bit into getting into treatments. And so as some of you may know, there's a growing body of literature focusing on psychedelics and the impact of psychedelics on various mental health outcomes, including substance use. And given that psychedelics are a traditional healing method in many communities of color, it's important that folks of color, including Black folks, are included in this research. And we're seeing that that's often not the case. And so Dr. Monica Williams invited me to collaborate with her and Dr. Ellen Davis on data collection, which was a large survey of adults, folks of color, specifically in the US and Canada, who endorsed using psychedelics and experiencing racial stress and trauma in order to identify or understand the impact of psychedelics on these various outcomes. And so we found that among those who use psychedelics, the acute intensity of the acute psychedelic effects, which is described as mystical type experiences, greater intensity of the insight experiences, and lower intensity of challenging experience, was associated with a greater change in mental health symptoms, including a reduction in racial trauma, stress, depression, and anxiety symptoms among folks of color. When we looked at what are some mechanisms that explain this reduction, we found that part of what explains a reduction is increases in psychological flexibility. So after taking psychedelics, people are experiencing an increase in psychological flexibility, and that's contributing to reductions in racial trauma symptoms. And then we did a serial mediation to look at substance use outcomes specifically, and we found that an increase in psychological flexibility and a reduction in racial trauma symptoms mediated the association and a reduction in both alcohol and drug use among folks of color. So this is preliminary evidence this provides additional evidence of the potential effects of psychedelics in treating racial trauma symptoms and substance use in folks of color. So I also have the privilege of leading a race-based stress and trauma empowerment group for veterans of color. And this is my co-leader, Ms. Kimona Spencer, who's finishing up her doctoral studies in social work. And what's really cool about this group is it's focused specifically on veterans of color, talking about the impact of racial stress and trauma in a military setting specifically with folks of color. We're intentional about not having white folks in the room because there are ways in which we're not always aware that we adapt or change our behavior to make white people comfortable. And we wanted this to be a space where folks could really be honest about their experiences and get the help that they need. And so this is targeted helping folks to understand their racial stress and trauma, what that looks like, and learn ways to cope with those stressors. And so there's a psychology fellow at Yale who's interested in adapting this treatment to think about how we could improve outcomes among those with substance use disorder. So that's one thing that we're thinking about in terms of how we might improve outcomes among Black folks, is borrowing from existing treatments and applying it to a substance using population. Another example is the Salabana Healing Circles. This was developed by the Association of Black Psychologists during the pandemic, specifically to target both anti-Black racism, ongoing anti-Black racism, and the new coronavirus pandemic. It first was developed for Black first responders and healthcare workers, but has since been expanded to broadly folks within the Black community. It was co-developed by Dr. Evan August, whose picture is up there, This is my colleague, Dr. Sherelle Bellamy, and we all got some funding to collect preliminary data on the cell bonding healing circles by providing the circles twice a week. The funding was specifically for Black healthcare workers in Connecticut, but it's virtual, and so anyone can join. These healing circles have been used so widely throughout the world, throughout the US, but also in the UK and Haiti. And people are more interested in participating in these circles after there's, been a tragedy in the community. And so these are specifically, or these circles have been designed specifically for people who identify as Black. The great thing about the cell bonding healing circles is that they are also led by people who identify as Black, and you don't have to have a clinical background. So that increases accessibility and the dissemination of this resource, and they're virtual. So it also increases accessibility, and they've been widely used, but we have little data on the effectiveness of them. And so that's our goal, is kind of understanding what the impact of these circles are having on mental health and substance use outcomes. And we're hoping to apply for some funding to study that further. But these groups are currently available. So if you're interested, you can always Google the Association of Black Psychologists and learn about what cell bonding healing circles are available. And also, we are still providing them twice a week, Mondays and Thursdays. And so if you're interested, you're welcome to drop in. But what I want to say about this is our community partners, folks with lived experience with substance use disorder, we had them participate in a group, and they thought that this could be a really important intervention for Black folks with substance use disorder. So we're thinking about how this could be applied to reduce substance use outcomes and to support recovery among Black folks. And then finally, another project that I'm invited to collaborate with Dr. Monica Williams on is the development of a protocol for treating racial stress and trauma using existing evidence-based approaches. And one thing that we're discussing is how could this perhaps be used for a substance using population. And so there's so many different ways that you can take when it comes to adapting or developing new treatments. And the approach that my research has taken is focusing on factors especially salient to Black folks, including thinking about how we can enhance racial identity development, and then focusing on racial stress and trauma. So to reiterate, the drug overdose death rate is a racial justice issue, and it is a matter of life or death that we develop treatments that are improving outcomes among Black folks. Current treatments are not meeting their needs. And so there's a need to, for treatments that are increasing retention. If folks are feeling satisfied by treatment, they're more likely to stay in treatment and therefore more likely to have improved outcomes. As I said, attending to relevant constructs is one approach for improving outcomes. So I want to thank my mentors, my community partners, research assistants, and funding for this work. And thank you all for your time and attention.
Thank you very much. That was amazing. I made a lot of notes.
Thank you.
So we have about 5 minutes now for some questions so that we can stay on track, and hear from Jude.
Thank you. Thank you for a wonderful presentation. Very nice. I want to tell you a story. My father was born in Barbados. My father was well established in his community, and he moved to Montreal. And my father knew absolutely nothing about racism. You're talking about racism. My father knew absolutely nothing about that. And so when he came to Montreal and he had to deal with racism and he had to laugh at jokes that were not funny, he didn't know how to handle it. And how he handled it was to take it out on us, his kids. My father never beat us. My father started beating us. As I said, you can't fight back. But he also became an alcoholic. And that really ties in to what you're talking about stress and racism and what that does to people. So I understand what you're saying about your interventions, they're good and I can see them working. But I want to know, what is your thought about, especially for immigrants, for that root cause? They get here and they're faced with things they've never before seen in their lives, and they don't have the tools to deal with it. That's long before they get there. They start drinking. I mean, cigarettes is an addiction, but that's the least of the problems. It's the alcohol, the other drugs, the partner violence, the intimate partner violence, the abusing of your children. Where do you see that intervention? How can you intervene at that point? How do you work with the immigrant? Do you have any idea, any hypotheses of what you can do there?
Yeah, well, first of all, thank you so much for sharing. And I'm so sorry. Yeah. That's real. Yeah. No, but I appreciate you sharing, because often we don't acknowledge these experiences. And as was shared yesterday, the importance of subgroup. We are not a monolith. We have varied experiences, and it's important that we're taking this into account, and that we're investigating, that we're studying this in Black subpopulations. And I think what's critical is there's not going to be a one size fit all. This is why I went over a couple different approaches we might take. Unfortunately, we're in the middle of analyzing the data for the qualitative interviews we just completed, but essentially what you shared is much of what we heard folks is kind of hearing their experience of how they develop problems and things that we're not considering in treatment. And I think what you're getting at is how do we address, or how do we acknowledge, or how do our treatments take into account the experiences of folks who come and become racialized later in life, and they don't necessarily grow up in this system, and how what that experience is and how that impacts folks, and then develop substance use disorders later in life. Typically, people in the U.S. Develop substance use, or the peak prevalence of substance use disorders in early adulthood, ages 18 to 25. But we know among Black folks, it actually tends to be later. And you can imagine among immigrant Black folks, especially if racism is contributing to the development of their substance use disorder, which we see that's happening. It can happen at even later ages. And so it's so important that, one, we're studying this in these subgroups, and that we're taking this into account. In terms of hypotheses, I mean, based on the interventions that, that I shared so far, I think that perhaps the Sawubona Healing Circles could be one potential avenue. The protocol that Dr. Monica Williams developed, that's an individual protocol. And so perhaps that could be an avenue, but I think that we should be intentional, work with community members to identify and develop treatments that would be effective for that group. So thank you so much for the question.
Highest rate of Black deaths based for substance abuse? Was it a lack of proper reporting in previous years, or was it something that you think sparked it during that time? Yeah. So important distinction, actually the death rate was highest among Indigenous folks in the US, but the greatest increase in overdose deaths was highest among Black folks in 2020. Part of the speculation for that, we had the COVID-19 pandemic, which exacerbated many disparities among groups. And so we did see that there was an increase in substance use among folks of color, and that access to treatment was limited, especially during that time among folks of color. So that's one suspect, but there's also research showing that there's increased contamination of fentanyl in cocaine supply, and that's contributing to increased drug overdose deaths, specifically among Black folks. And so some folks may be intentionally using opioids, whereas some people may think they're only using cocaine, but really there's contamination of fentanyl. And so people are unexpectedly overdosing. So that's kind of been the main focus of some of our work lately, specifically among Black folks, since we know that cocaine tends to be the substance of choice or higher prevalence among Black folks.
Oh,
Okay, actually, I don't have a question. I just want to add that we have add a comment to what you just explained, that we had a similar study in Canada that looked at COVID impact in the Black community across the country, involving over 1,300 people, ACB people, Black Canadians. And we did find too that there was increase in substance use during the pandemic.
Mm-hmm. Yeah.
So quite similar to the explanation you've given. In fact, we think there was actually underreporting, that it's actually higher. Somebody who works in the community was at the first presentation we had of the findings, and he said, this number actually hasn't captured what I'm seeing in the field.
Yeah.
Doing this kind of work. It is so hard to find this data, so I'm grateful for you, for Dr. Jude, for Dr. uOttawa, and others today. So thank you.